Hello, my name is Deb Colman, and this is my quality improvement presentation. I work on an OB unit in Wisconsin, and I take care of mothers and new babies. I am mostly a special care nursery nurse, but I also take care of postpartum mothers. I do not work on labor and delivery, but I do work as a nurse that comes to the deliveries to take care of baby after they've been born. So my quality improvement problem identification is post-birth. More infants are displaying signs and symptoms of neonatal abstinence syndrome, otherwise known as NAS. These infants' mothers have a history of illegal drug use in their past, or they deny current or recent use of substance abuse. The problem, these pregnant mothers who concede to illegal drug use in the long-term past but are not currently using, or they concede to being sober for a long time and they are not being drug tested on admission to labor and delivery. So let's talk about neonatal abstinence syndrome. This is a set of signs and symptoms that a baby can show when they are going through withdrawal, which includes tremors, irritability, poor feeding, poor sleep, increased muscle tone. They sometimes have problems with fast breathing, tachypnea, and they are very hard to console. So we use the Eat, Sleep, Console intervention. It's very simple, but sometimes they do need medications. Simple intervention to my problem is that all mothers, upon being admitted to labor and delivery, must have mandatory standard procedure collection of a urine drug screen. And it must be universal. Everyone must provide a urine drug screen upon admission. So this is my fishbone diagram. I have people, process, environment, and management all included in this diagram, which lead to why infants are displaying the NAS and why we do not have maternal drug screens for those infants. So the people include the mother, the nurse who's admitting the mother, and then obviously the baby who's the vulnerable patient. The process is that, why is this happening? The EMR is not alerting the nurse to, possible drug history. Admission questions aren't being addressed. And the UDS, or the urine drug screen, is not being done. The environment can also be very unstable. The nurse might have bias or judgment towards the mother. Family of the patient might be present, so the mother might not be comfortable sharing. It could be an overstimulating environment. Also, management can be involved because short staffing can cause these things to get missed. We function a lot like an emergency department on OB, so moms come in quick and they deliver quickly, and sometimes these things can just get missed. There's a lack of support towards employees who need to voice their concern, and there's a lack of education on the importance of screening and, getting preventative treatment for these infants. So that is getting missed. What is my outcome? 100% of these infants, all infants who have a maternal known positive drug screen, will be given the proper treatment in the first 72 hours of life, and treatment may continue. Sometimes these babies need to be admitted to the special care unit for medication administration, and they can be back there, for up to 30 days, sometimes longer. But the main thing is that first 72 hours of life, monitoring that infant, and then giving proper treatment for as long as that infant needs. My research articles on my supportive interventions. One article was looking at the long-term outcome of these kiddos who were exposed and who also were diagnosed with the NAS. And 19% of those kids were exposed, and then some of them had higher rates of mental health, behavior problems, eye disorders, and then musculoskeletal and GI problems. So key findings were early prenatal screening is key so that we know how to take care of these kids and we know how to treat them and take care of them as they grow and give them the support that they need. Another important article I found really talks about the mother and how we could support her. And I think that's really important. These mothers struggle with addiction, and just because they have an addiction doesn't mean they don't love their baby. So key topics include collaborating with social workers to help support these mothers, determining the obstacles that these mothers are struggling with, that get in the way of taking care of their infant, like transportation issues, financial housing problems, and making sure that the mother is included as the vital source of comfort for her infant. Very important. These bonding moments help the mother feel empowered and connected. And I have a quote down there that talks about mothers need to feel valued, and it can assist the mother to meet her sobriety goals. A stressful, tense, and disrespectful environment can lead to the opposite effect and lead that mother back down the hole of substance abuse. So really it's about the health of the mother and the baby together. Interventions that are evidence-based. So intervention 1, obviously initiating that universal drug screen testing to all patients being admitted to labor and delivery. Ensuring that social work is involved from the beginning during prenatal care. Also initiating, once the baby's born, initiating that meconium drug screen and testing for the infant if the mother has a positive screen. If the mother does refuse the screening on admission to labor and delivery, that's fine. The mother has to consent to that or not consent, and that's okay. But if that mother does not consent, we need to test the infant. And that is something we can do without the mother's consent. Intervention 4, creating that supportive environment for mother and baby. And then intervention 5, close assessment, monitoring, and use of those non-pharmacological methods such as eat, sleep, console to provide the best possible treatment for the infant. So how am I going to implement and gather this data? The data collected, I will collect it over 6 months. That will include the mothers tested, the percentage of mothers that tested positive from the EMR, and if or if not their infants were showing signs of NAS. It will be gathered from the EMR. It will be displayed to leadership in the percentage of mothers who consented, the percentage of mothers who did not consent, the percentage of children who displayed NAS, and then percentage of children who did not. And then I would do a run chart as the best way to display the data because it has the amounts there with the vertical and horizontal data showing the frequencies and percentages. Implementation, step 1, I would definitely meet with the clinic director to talk about early testing and education for mothers during their prenatal appointments. That is key. Early intervention is key. I would then schedule bi-weekly meetings with outpatient, inpatient directors to discuss, okay, how are we going to make this happen? And then creating that IHI improvement checklist to determine who would be good team members. And then the team, the technical expert, the person who's really good with the EMR, the RN leader, obviously the director and the supervisor for both the clinic and the hospital, who have the means to implement the change, and who also stay in communication with the day-to-day leader. The team leaders and clinicians, pediatricians, physicians are vital. The social work leaders are vital. And then those lab techs, those ones that are actually running the testing, it's very important to stay in communication with them as well. Project sponsor would be the executive or leader who holds the jurisdiction to help implement this change, and then the day-to-day leader. That would be the leader who would analyze the data along with the physician, share it back to the whole team, and then they would also propose the next steps once the simple PDSA is complete. Here are my references for you to see. And that is the conclusion of my quality improvement presentation. Thank you so much.